Thank you very much for the opportunity to present today. I have no conflict of interest. Component separation is utilised to restore the midline without tension, and in addition, transversus abdominis release allows a large mesh in an interstitial plane. Over the years, we've noted concerns about component separation, including donor site problems, lateral hernias, dehiscence of posterior layers, and intraparietal hernias. And in addition, recently, we've become concerned about potential loss of function of the lateral muscles with possible spinal and respiratory problems in the long term. We're talking 10 years plus. Botox has been around for 40 years. It results in flaccid paralysis and pain modulation, and it has a slow onset of a couple of weeks, and it lasts for up to 3 months. It's expensive, and it's unfortunately not reimbursed by health insurers, so many surgeons are reluctant to use this, and it's been increasingly used in pain management. It's indicated for complex ventral hernias with linear defects greater than 7 centimetres, recurrent or multi-recurrent hernias, loss of domain, and in patients with chronic pain issues. It's administered as a single outpatient session under ultrasound guidance with 6 injection sites as per SMOOT, with 100 to 150 units per side, and then operate 2 to 4 weeks later. This shows how we perform the technique, injecting directly into the lateral muscle bellies. It's well tolerated with some distension and bloating, weak cough or sneeze, and a small percentage of patients have back pain, which is treated with abdominal binders, physiotherapy, and reassurance. Its effect is to elongate and thin the contracted lateral obliques, and this allows the abdomen to take on a more anatomical appearance, and this results in reduction in defect size. These are the results from Nabil Ibrahim's group in Sydney, the Hernia Institute of Australia, of 122 patients, mean BMI of 32 and mean transverse defect diameter of 11.5 centimetres. 73% have had previous repairs, with 32% had loss of domain, and the mean preoperative unstretched length gain was 4.4 centimetres per side. All hernias were repaired, and the vast majority using a laparoscopic IPOM plus with closure of the defect. 29% required a hybrid approach with laparoscopy and mini laparotomy, and 16% required limited single pore anterior component separation. There were no episodes of abdominal hypertension, ventrally compromise, or wound dehiscence. Then there were no hernia recurrence with a mean follow-up of 20 months. So BTA avoided component separation in 84% in this cohort with major hernias. So why is BTA useful in major hernia repair? Well, if we look on the this side here, when we have a hernia, we have detached muscles, and these muscles contract, and then there's a resulting shortening and fibrosis. So if we close the defect and did nothing else, there's undue tension on the wound due to this poor muscle compliance, and we've got a recurrence rate of about 50 to 60% over 10 years. Now contrast that to what happens in laparotomy. So we have the same cohort of patients with, and we make a big incision, so we've got a large defect, but in these patients we have good muscle compliance, so when we close the defect there's less tension on the wound, and we've got a hernia rate of about 20 to 30% over 10 years. And if we add mesh to each of these scenarios, you know we can reduce the recurrence rate by half. So, although there are many factors which may account for the differences in hernia formation and recurrence after simple repair between hernia and a laparotomy, shortening and contracture of the abdominal muscles in hernia is probably a major factor. And it's well known that detached muscles lose their compliance. The plastics and orthopaedic surgeons have known about this for years. And this can be improved by a period of gradual stretching of the poorly compliant muscle, which we call the plasticity of muscle. And BTA-induced flaccid paralysis probably allows the constant intra-abdominal pressure to gradually stretch the muscles, restoring abdominal compliance. And BTA may improve plasticity and avoid component separation, such as TAR. So if we look at our diagram, and we've got patients here with hernia, we've got detached muscles, you've got two options. One is you can treat these contracture shortening and fibrosis with component separation and put a large mesh. And although we don't have 10-year data, we can probably suspect in good hands the recurrence rate is probably in the region of about 10%. Or what we can do is treat this contracture shortening and fibrosis with BTA, and if we can reverse this contracture shortening and fibrosis, maybe we can put them in the same algorithmic group as what we do at laparotomy, and that is we have good muscle compliance, close the defect, less tension on the wound. We have a hernia rate of about 20 to 30%, 10 years, but if we put a small subrectus mesh, we know that short-term results show that the recurrence rate can be in the region of about 5%, but maybe we can get it to 10% over 10 years. So BTA addresses the main cause of tension in major hernia repair, and that's the contracture of the detached muscles. Component separation does not directly address contracture of detached muscles. BTA is associated with much less complication than component separation, and component separation may be overused and best utilised in situations where BTA-induced flaccid paralysis has not allowed closure of the defect, or other unique situations such as lateral or peristomal hernias. So in conclusion, BTA is safe and well tolerated. It should be used with other preoperative optimisation strategies. It enables fascial closure at the midline or near midline. There's significantly reduced need for component separation. It may enable us to perform a MIS repair, and it's good for postoperative pain relief. Now, the other advantage of BTA is that it does allow, its effect lasts for about 3 months. So during this time, we actually have improved compliance of the abdominal wall and decreased abdominal pressure, which are important distraction forces in a hernia repair. So maybe it may reduce our recurrence rate, it may reduce the size of mesh required, and it may enable operative repair in high-risk patients by reducing the risk of abdominal hypertension, and we believe that it may become standard of care in large ventral hernia surgery. Thank you very much.